Hello, everyone. Welcome to another Rafael Medina subspecialty. Today we have pulmonary and critical care, and I'm super excited to have two guests today. We have Dr. Anna Fretz. She's a pulmonary and critical care fellow on NUCLA. She, by coincidence, my first episode on VMR, she was facilitating, and now I am here doing the facilitation where she is discussing. So it's a really, I'm really excited about it. And we have Rishabh, who is like a PGI3 of maternal medicine and Sinai, and he will be a pulmonary and critical care doctor soon. So you two want to say hello?
Rishabh, please go ahead.
Thank you. Hi, everyone. My name is Rishabh.
Hi, everyone. I'm Anna. I am so nervous to do this. I was just telling Deborah and Robbie and Rishabh before this. I haven't discussed a case live in a very long time. And when they told me it was going to be a palm crit case, I was like, please let it be critical care. So Rishabh, whatever you have, I inevitably have to be ready for. What I've learned so far in my 9 months of palm crit training is that I am a whole lot more comfortable with crit than I am with palm. It's like being a medical student all over again. But anyway, I'm really excited for the learning opportunity, and I'll take all the help that I can get in the chat.
Yeah, that's what they say, that critical care is the easier part, but palm is the more difficult part in the training.
Totally. It's like, yeah, so much to learn for such a small space of the body. Who would have thought?
And could you tell us why did you choose pulmonary and critical care?
Yeah, absolutely. I can go first, and then maybe Rashab, since you're closer to that decision, you can share your why you chose it. I chose pulmonary and critical care for a few reasons. One is that I love taking care of critically ill people. I really like working in an environment where you get information quickly. You kind of engage in this really expedited clinical reasoning process where like diagnostics and therapeutics are going along hand in hand. And then you get quick results in the form of objective data for like if you did or did not do the right thing. So kind of like that very fast feedback loop, I find both exhilarating and just like a really fun kind of diagnostic exercise. I really like taking care of patients at the end of life as well, which is, a big part of critical care. I like it, not joy, but like I find it a rewarding experience for talking to families and kind of seeing how loved ones in people's lives can show up for their families and show up for each other during really difficult times, and kind of helping people accept what is an inevitable part of human life, the dying process. And I, when I was like I also really like procedures. And so I wanted to go into a procedural field, but I also loved being a whole body doctor. And so I think this is the one subspecialty within medicine where you like very much still get to be like, at least in the ICU, a whole body doctor. And it's like in really sick patients. And I really like that combination. And I am having a great time in training so far. So I am happy with my decision to do fellowship, even though it's very tiring. It's super fun and very, very rewarding. Rishabh, why did you choose Palm Crit?
So interestingly, my answer is kind of the same, but I think in different words. I think for me, the most important reason was, I think it's the best field. Like if you like just like going deep into physiology to understand what's really going on. And like patients in ICU, uh, just like you have to think really fast what's going on, think about the physiology. It's like a little bit of detective work. And even like Palm is a lot of physiology. So I'm like really driven by physiology. And then I think the second thing for me was the procedures too. Both Palm and critical care, both part of the fellowship field, gives you a good balance between practicing medicine and doing procedures. And I think third thing is it's very rewarding. Like end of life, I feel it's very rewarding to guide families and patients through that process.
Thank you so much for sharing like incredible answer, and I think it's really inspiring. I think Parisa, if you can share the screen, we can start with the case. Rishabh, you can give us the first aliquot.
Awesome. So can you hear me properly before I start? Awesome. So the chief complaint, so we have a 50-year-old male presented with complaints of confusion, agitation, and palpitations over the course of the last 1 week. And should I just go to the HPI now? Yep. So we have a 50-year-old male who presented with complaints of confusion, agitation, and palpitations for the past 1 week. So his story is pretty interesting. His office manager called EMS after he found the patient to be confused, altered, and agitated outside the office building. The office manager told EMS that the patient had been feeling unwell for the last week. And during the last week, he had been drinking hard liquor and not eating anything, so no food intake. But as per the EMS note, he was oriented ×4, but his speech was very erratic. So initially, he was taken to another hospital, not our hospital, and there he was found to be severely dehydrated, and his pressures were borderline, and he was tachycardic. So he was given about 5 liters of normal saline with a good improvement in blood pressures. But after that, he was found to be agitated and paranoid there. So they treated him with diazepam and they did a psych evaluation as he was accusing the nurse of trying to kill him. So when psych saw him in that outside hospital, they cleared him for discharge, but given persistent tachycardia and concerns of alcohol withdrawal, he was transferred to our hospital. So when he presented, these are the only complaints. He denied having any fevers, chills, shakes, or chest pain.
And what are your thoughts about this first aliquot?
Yeah, it's very interesting. And I always find cases extra challenging when there's already like some diagnostic momentum that's being made by a team. Like somebody's like, oh, he's withdrawing from alcohol. So I'm like consciously realizing that somebody has already labeled this as alcohol withdrawal and like trying to take a step back to be like, I make sure I'm thinking about the patient's it seems like their cognitive status is maybe where I'm going to focus in on for the first aliquot, although keeping this like kind of palpitations and low volume state in the back of my mind. So, you know, when thinking about like altered mental status, I too go down, as sure many of you do, like my MIST framework. So, you know, I'm definitely getting a signal that this patient could have some type of underlying metabolic disturbance. We've heard about recent heavy alcohol use. You know, are we going to find out that they're like in alcoholic ketoacidosis and their acid-base status is really strange? Are we going to find out that they're really hyponatremic and they haven't been taking enough osms in? And that could be contributing to their altered mental status. Within the I bucket, infection, you know, not really sounding like we're getting anything localizing, at least based off of the review of systems, aside from something within the CNS. So could this be a primary CNS infection leading to the patient's altered mental status? Within the structural category, it doesn't sound like there's anything tremendously localizing on exam, although I'm going to be really interested in a good neurologic exam for the patient right off the bat. And then within the toxin bucket, so both thinking about whether some type of toxic ingestion or similarly a toxic withdrawal, which is, you know, the leading thought for this patient in the form of alcohol withdrawal. I'd be doing my toxic handshake on a patient, which is taking a look at their pupils and feeling whether or not they're warm or if they're sweaty or dry on exam, but also like looking at their vitals. I think that will be really helpful in kind of getting a sense of if we need to be concerned about some type of toxic ingestion for the patient. The last thing I wanted to mention, actually, I'll mention two other things. The tachycardia that the patient, or the palpitations that they're reporting, I'm wondering if that's going to come into play. You know, there are certain like endocrinopathies that I would think of as etiologies of driving both altered mental status, but also tachycardia, especially things like thyroid storm. That's usually a really dramatic presentation, but certainly like somebody could be totally revved up, really agitated, kind of like hypomanic. And so that would be something that I would be interested if kind of there are other laboratory abnormalities that fit that, or other things on exam that fit something like thyroid storm. And then while I'm not concerned about it for this patient, because I normally think about more altered mental status when it's on the obtunded end of the spectrum. Just like my critical care brain, anytime I'm seeing an altered patient, things that I like look for are what their pupils are, and what their blood glucose is, because those are like two immediately reversible things that you can do that can, you know, potentially restore a patient's obtunded mental status. That doesn't really apply as much for this patient because they're more on like the hyper end of the spectrum. But would definitely be things that I'd still be interested in. I guess the last thing I'll say is, you know, when seeing people who are really on the activated end of the spectrum, I tend to wonder more about like comorbid psychiatric conditions as well. And so I wonder if eventually we'll get maybe a little bit more past medical history or social history that might hint at some type of like underlying psychiatric component that could be decompensated. Yeah, I'm interested to hear more about like what we know about the patient, and what their exam is, and what some of the prelim labs are like.
Fantastic. Rishabh, can you give us more information, please?
I forgot to mention one piece of information. He also complained about a 20-pound weight loss. That's one thing I forgot to mention in the review systems. But for the past medical history, the only thing he had was alcohol use disorder. He did not have any surgical history, no significant family history. Uh, for his medications, he was not taking any medications at home. And for his social history, he drinks about 8 to 10 drinks per day, which includes beer, whiskey. His last drink was about 2 days ago. He says that he needs a drink. He needs a drink to help him sleep. For occupation, he's been working in the trucking industry for about 15 years. He lives at home with a significant other, but did not have any tobacco smoking or illicit drug use, and no known allergies for him.
And with this alcohol use disorder, what do you think about now?
Yeah, you know, certainly I think alcohol withdrawal could definitely fit many aspects of this patient's presentation. This patient, you know, in the setting of being like so agitated, we don't know what their vitals are yet, aside from them being really tachycardic, but like, you know, could be in the DTs or alcoholic hallucinosis period, depending on like their time from last drink. The degree of like paranoia that the patient has seems like a little bit out of proportion to what I expect to see for something like alcohol withdrawal. So I wonder if maybe there is, you know, even though the patient right now is reporting that they only use alcohol, they're altered, we might eventually get other information that there are other substances at play for the patient. So what I will say is, like, while there are pieces of the story that I think could fit something like alcohol withdrawal, there's other pieces that don't as much for me. And again, that's like the degree of paranoia that the patient has, the weight loss I can't really make sense of in the setting of alcohol withdrawal, and would be like a separate problem that I would be tracking for the patient. And I really think, you know, seeing what this patient looks like on exam, like, am I seeing tongue wag? Am I seeing tremor? What are the pupils like? Are they really dilated? To get a better sense of like, how much of the patient's presentation can I explain based off of the known history, and what pieces aren't fitting? I think both of those elements are equally important, what fits and what doesn't fit.
Fantastic. Rishabh, can you give us the physical exam?
Yeah. So the patient was had low-grade fevers, 37.9 Celsius, heart rate was 105 per minute, respiratory rate was 28 per minute, blood pressure was 129/84 when we examined the patient. The patient was desaturating on room air to 86%, and we had to put the patient on oxygen. So on 3 liters, he was 95%. Otherwise, the patient was awake, alert, oriented times 4. The patient was a little paranoid and talking like tangential speech and paranoid speech. Um, for his HENT exam, no pallor, no icterus that we saw. He had intact eye ocular movements. His oral mucosa was moist. He did not have any oral lesions. His respiration he was a little tachypneic, but not that labored, and he was clear to auscultation. For cardiovascular, he was tachycardic, but did not have any murmurs, erupts, or gallops. No JVD, no pedal edema. For GI, everything was normal, non-distended, non-tender, normal bowel sounds. Neurological wise, he was completely oriented, and he had 5/5 strength in all 4 extremities. His sensations were intact as well. So nothing neurological that we could see. And extremity and skin wise, we didn't find any rashes. His skin looked moist, fine, and his extremities, no lesions, no deformities.
Can I ask on the physical exam, did the patient have increased tone in their extremities?
No,
Okay. And they were non-meningitic.
non-meningitic.
Why did you ask that?
I'm like I was hoping we would get a more dramatic exam for something like alcohol withdrawal. And then, this would be a one and done, and we could just talk about the patient's hypoxia, which is obviously their most interesting problem. But I don't think we're getting a huge signal. I'm not hearing that they have like a tremor on exam. I'm not hearing that they have like tongue wag. And so, is that because the patient just got diazepam and like we're effectively treating that, and in 2 hours time we're going to see that? Maybe. So, again, like the delta of time to kind of see the natural progression of, we've done a treatment, we need to see if there was like an appropriate response. But this exam in isolation does not fit with alcohol withdrawal to me, especially given that we're not hearing that he like has active headaches right now. He's not nauseous, he's not throwing up, that type of thing. But like they seem to have like, again, this like really strange disturbance of their cognitive status with like the degree of paranoia and whatnot, which really makes me think about, again, other type of toxic ingestions. It makes me think about underlying psychiatric disease. And then certainly there are like primary CNS infections, that could result in something like having paranoia, or like even autoimmune and encephalitis and whatnot. So I'm really interested to kind of see the trajectory of the patient's mental status, to see if like this is something that's going to become a huge feature of the case, or if this is, like maybe the patient just happens to have like a new, psychiatric illness in the middle of his life for whatever reason. And so that's why I was asking so many questions about his exam. Are we going to get more information, or should I talk a little bit about the hypoxia?
You can share a little bit about the hypoxia.
I mostly just wanted to encourage people at this point, because I really think we're hearing a fairly clear lung exam, but I still want to get a chest x-ray or like some form of chest imaging, to get a better sense of what the patient's parenchyma looks like, if there's any evidence of like chronic lung disease, if there's any evidence of like an acute process, like an acute consolidation or something like that. I want to get a blood gas as well to figure out if this could be related to like hypoventilation, given that they have altered mental status, although it doesn't sound like they're obtunded when I more expect that. But I would just encourage people that like when you see somebody on oxygen, that needs to be a problem on your problem list. I feel like so often I like go down, I admit patients in the emergency department, they're on 2 liters of oxygen. And then like we don't think about it until like they're ready to go home on discharge. And you're like, oh, this patient's been on oxygen the whole time. Why is that the case? And so when you see somebody on oxygen, you should figure out why. You should also try to turn it down because sometimes you just put people on oxygen and they don't actually need it. So that would be what I encourage you all to do. Is if they're on oxygen and they truly need it, that is a problem that needs to be addressed.
I love it. Add to your list. Rishabh, can you give us the first labs?
Yeah, I just wanted to add that the patient had gotten diazepam about 30 minutes before we examined him. And somebody had, like the other team that had examined him, the ED physicians, they told us that he had some tremors. But we didn't see any tremors when we examined him. So coming on to the labs, so starting with the blood cell count, his WBC was 6.93. His hemoglobin was 10.6, hematocrit was 32. Platelet count was 274,000. For his CMP, sodium was 137, potassium was 4.6. His chloride was 101. His bicarb was 30.3. His BUN was 11, creatinine normal at 0.95. His glucose level was 158. The anion gap was 6. The albumin was normal as well, 3.8. Total protein of 9.3. Calcium was 9.2. The ALP was 64. AST was 38 with an ALT of 19. And the total bilirubin was 0.5. We did get some other labs. We got a CPK, which was 205. Lactate was normal at 0.9. TSH was kind of borderline low at 0.41. D-dimer was borderline at 0.58. The ammonia was 28. And for other stuff, we got a urinalysis, which was unremarkable, especially for an infection, but did not show any other thing as well. We did get ethanol levels, which were less than 3. And we did get a urine toxicology, which was negative for everything that we tested. And that's pretty much it with the labs. Do you want me to continue with the imaging or take a pause?
What do you prefer, Anna?
I'm curious about the imaging, but I do wonder, do you have a serum osm? And then do you also have a VBG for the patient?
Yeah, 1 second. So we got an ABG that was 7.38, 42, and the PO2 was 62 on 3 liters. And the serum osm, I don't have it written on top, but I think it was 320 something.
Okay. I'm curious what the imaging shows, and then I can share after why I asked about those things.
Sounds good. So we did some micros as well. We got a COVID, RSV, influenza, which was negative, and then we got a strep pneumo, Legionella, which were negative as well. We got blood cultures, which were negative too. For imaging, we got an EKG, which showed sinus tachycardia, but no other abnormalities. And we got a CT head, which did not show any intracranial pathology. And then we got a chest X-ray. I actually wanted to show the X-ray before I gave the radiological findings. So is it okay if I'm sharing my screen?
Yes, you can share.
Okay. So this is the chest X-ray. Do you see it?
Yes, yes, we can see.
And the radiological reading was there's no acute cardiopulmonary process going on, um, which I kind of agree with. I don't see anything in particular. And if you see something, you can jump in.
I don't see anything major either. The lung fields, the expansion isn't great. And so I'd say like the lung fields look like a little bit busy for someone who like doesn't really have any medical problems. Like a lot of, this is a middle-aged person who we're told has like, lung disease. He doesn't smoke. He doesn't have any cardiac history. And like, it kind of just looks like there's a little bit more stuff, haziness than I'd expect. But I don't see any like clear consolidation or anything that stands out dramatically. The patient's heart size looks okay. Maybe a little bit of like perihilar fullness, especially on the right-hand side. You can like clearly see his like right bronchus and then his right BI come down, and there's like relative kind of like hyperlucency next to it. And so that could be like a little bit of lymphadenopathy within the chest. It could be a little bit of pulmonary vascular congestion. So there could be a little bit that could like lead to the busy appearance. But yeah, it doesn't stand out a ton.
Thank you. Yeah, I think you're the expert right now than the other people. So coming on to the CT scan, so there I'm going to show 3 images. We got it 2 days after we got the chest X-ray. So this is the first image. Yep, and what I see here is like a lot of ground glass opacification. That's like the major thing I see. Anything else that you want to add, Anna, that you see?
The only thing that I'll point out is that like this image in particular is a really nice job of like sparing the periphery. And so you can like clearly see if you go right up to like the pleural lining, the ground glass that you see, it's fairly homogeneously distributed throughout the lungs. You don't see something that's like incredibly like gravity dependent, suggestive of like pulmonary edema. You also don't see a lot of the pulmonary edema like originating right around the vessels, which could be seen in the setting of like a hydrostatic pressure gradient, in the setting of somebody who's like acutely decompensated from a heart failure perspective, which I think of on my differential for ground glass opacities. It's kind of like very, like I said, like homogeneously distributed with the little bit of subpleural sparing, which is like a common thing that we see for like many different inflammatory processes that can impact the lungs. Yeah. Can you go back to the other images and we can just make sure the patient doesn't have any like lymph nodes or anything? It doesn't look like, at least, it's hard to see on these windows, but it doesn't look like the patient has any like huge lymph nodes, like right around their trachea, right around their main stem takeoffs. And the other one. Great. And then there's on the right, you can kind of see that area in the posterior aspect of the lung that looks like a little bit more densely consolidated. And like, could you convince yourself that there's this area of like lucency right in the middle there? It's a little bit hard to say. I will say this image, like it's a little bit of like an expiratory image. And so this patient might have a little bit of atelectasis there. It's like coming in, it could look like rolled atelectasis, but that could be like some type of focal infiltration. One thing that I am wondering, and I'm just going to say this out loud, and it's definitely probably wrong, but when I'm looking, it's a little bit more apparent on the left side than the right. When I'm looking in some of the areas where you see ground glass, it's almost as if you see like these tiny little like cystic structures that are outlined by ground glass. And that is something that you can see with patients that like have things like PCP. I don't necessarily think this is like, that's what this is, but that's kind of an interesting imaging finding to me.
Nice. I love it, the pearl. Rishabh, could you pull out the X-ray again? I want to ask you two can answer the question, like if you have any systematic way to read the chest X-ray. We have a lot of interns that will start now. So if you want to share any tips or anything that you two use to when you are in front of a chest X-ray.
I'm happy to. And then Rishabh, please feel free to support me through this. And so I start by looking at the patient's airways. And so I'm looking for that very dark structure coming down the middle of the patient's trachea to make sure they don't have any evidence of like tracheal stenosis. Their airway looks good. See if they have like a breathing tube in place to make sure that's in the right position. Sorry, I'm going the ABCD method, and I think there's like more EF and whatnot, but I will say I probably don't have like the most structured approach to it. B, I'm looking at bones. I will say I'm really bad at looking at fractures. Like it needs to be a pretty catastrophic fracture for me to pick up. But like the easiest for me to see are the clavicles. Are the clavicles like nice and symmetric? You don't see like any dislocation around the sternum itself. The rest of the bones look okay to me. I don't see any obvious fractures. C, I'm going to look at the cardiac silhouette. So does the cardiac silhouette look enlarged? This is an AP film, and so the cardiac silhouette to me looks about half of the penetration of like half the diameter of the whole chest, which is about appropriate in an AP film. You'd expect it to be smaller in a PA film for a normal sized heart. D, I'm going to look at the diaphragms. Your right diaphragm is usually a little bit higher than your left because of the presence of the liver. That's the case here. It doesn't look like there's anything that's super elevated and the patient has like, one of their diaphragms that's paralyzed or anything like that. And then you also see nice, crisp costophrenic angles. E, I don't even remember what E is, but I'm just going to jump right to lung fields because that's what I look at next. And so again, this is kind of just where I'm like scanning down both sides. I'm looking, do I see things like big consolidations? Those are areas that are like wiping out and like taking away a silhouette from a structure next to it. That would be something like a consolidation. Or am I seeing something that's more like a hazy or like reticular pattern of lines, which could be like the setting in someone who has like an interstitial process, or if they have something like pulmonary edema, where they have just like fluid filling up their interstitium and kind of going out into their alveoli. And so I'm looking, for those like linear patterns, for dense consolidations. And then the last important things to look at, well, actually probably the first things that we should look at are things like the quality of the film itself. So like, can I see, do I have a good quality film? Is the patient taking adequate inspiration? When you're comparing new films to old films, do you have similar penetration or inspiration, or is the patient not inspiring so everything looks crumpled up? And to me, this looks like a pretty good quality film. Like I can count about 8 ribs down anteriorly. And then I think in terms of the penetration, it also looks appropriate. And then their rotation, looking again at like the sternum coming in, is it roughly symmetric? Yes, it's roughly symmetric. So I don't think the patient's too rotated. What do you use other things, Rishabh? I know there's a couple different like systematic approaches, and mine's not super systematic.
I use the same ABCDE, and I look at the rotation and the exposure before going to the ABCD. And just one thing to add, E is just extra things like chest tubes or leads. Like this patient, you can see like 2 leads going out. So it's important to like look at if there's any chest tube going in, if there's a pacemaker or an ICD on the top. So E is just extra things, but everything else is the same.
Thank you for reminding me of the E.
Can we, Anna, do you want to complement anything with the labs, with the imaging before we go for the next aliquot?
Yeah, maybe if we could go back to the labs themselves. I didn't get a glucose on the patient, but I am wondering, like, if in the setting, although I do trust, it sounds like we have an exam that at one point was consistent with alcohol withdrawal that's responding appropriately to benzos. Other things also would respond to benzos. So like I'm like cautiously being like, okay, maybe this is alcohol withdrawal. I definitely would want to get an osm gap for the patient to make sure we don't need to be worried about like toxic alcohol ingestion for the patient. Given that their serum osms are pretty elevated. Usually like 310 is what I think of as the upper limit of normal. And especially with like how agitated and paranoid the patient is, although they don't seem to have like any other type of acid-base disturbance that often goes hand in hand with toxic alcohol ingestion. But I would want to know glucose 158. Maybe somebody can calculate the osm gap for me. So that's something that I think we should be on the lookout for. In terms of the rest of the workup, I mean, we do have, in terms of like thinking about like diffuse ground glass opacities in the lungs, things that I think of. So is this something like pulmonary edema? I'd want to do like a quick bedside ultrasound for the patient to make sure it looks like they have like normal cardiac function, getting a BNP to see if there's any evidence of like stretch. Other things that can look like diffuse ground glass opacities, diffuse pulmonary hemorrhage, that really there's like usually a pretty striking clinical history that goes along with that. So a patient's like reporting that they're coughing up blood. It rarely is like very subtle in presentation. The way you diagnose that would be through a bronchoscopic exam. But you know, if that's a history that you got that the patient was having hemoptysis, so you were to see DAH on a bronchoscopy, I would be sending off like an autoimmune workup, looking for things like vasculitis, especially in the lungs, things like lupus and whatnot, glomerular basement membrane disease, although we don't get any signal for renal dysfunction, we have a normal UA. Infections definitely can also present with diffuse ground glass opacities. We do have already some viral studies back with the COVID RSV being back. You know, I'd be interested in things like flu. I would also, depending on the time of year, just on like a full RVP, because we were seeing this like huge resurgence of all these different URIs. You know, I would send an HIV test for this patient. And we don't get any like other signal that they're immunocompromised in other ways, but if his HIV test was positive, then I would send a beta D glucan to evaluate for things like PCP that can also have diffuse ground glass opacities like this. And then depending on what institution you work at, there are these things called like sputum biofires. I'm working up at the county hospital right now, and we have the sputum biofire that we send, and it has like really, really good sensitivity for like everything under the sun that can infect the lungs. You do need to have a good induced sputum sample. But you know, things like walking pneumonia, quote unquote, could definitely also present with like diffuse ground glass opacities. I think all of these other things are a lot more likely in the absence of any other pulmonary symptoms than like a new type of like interstitial lung disease, where we're seeing just like the upfront inflammatory process before seeing considerable interstitial changes within the patient. So I would do that type of workup first, the infectious workup. This patient may, depending on the, especially the trajectory of their respiratory illness, may end up needing a bronchoscopy to get like deeper samples and to look for things like DAH. That's where I would start.
Rishabh, can we go for the next aliquot?
Yep. So I'll go to the hospital course now. So when the patient initially came, the patient was scoring really high on SIVA, and the patient was started on standing Librium and diazepam sliding scale. But we saw that the patient was hypoxic, requiring 3 liters nasal cannula. The chest X-ray initially that we saw did not show anything much significant. And initially, the hypoxia we thought was secondary to getting excessive fluids in the other hospital. So the patient had gotten 5 liters of fluids in the other hospital. So we thought there might be some component of pulmonary edema from getting a lot of fluid. So we gave a couple of Lasix doses, IV, but the hypoxia did not improve. And then patient started having some low-grade fevers, which we were initially attributing to alcohol withdrawal. But about day 3, the patient started having high-grade temperatures above 39 and persistent tachycardia. And the other things on the CEVA protocol, he was not scoring high on the other things on CEVA protocol. So we ordered the CTPE, the images that I saw. It ruled out a PE, but it showed ground glass opacification and a little bit more consolidation in the right lower lobe. So we initially thought that it might be just a pneumonia. So we started the patient on ceftriaxone as azithromycin, but the patient kept on becoming more hypoxic, was still febrile, tachycardic, and at one point we brought in the antibiotics from ceftriaxone to zosyn. But around day 6, the patient had a rapid response as the patient was saturating about 85% despite being on 6 liters nasal cannula. And at that time during the rapid response, there was a repeat chest X-ray that the rapid team got. And I just wanted to share that chest X-ray with you just to see the progression from the first chest X-ray. So this is what the chest X-ray looked like, which they got in the rapid response. And it looks pretty different from the first one. So this was the first one, and this is the one during the rapid response. So given the patient had so much ground glass opacification and the patient kept on becoming hypoxic, the patient was given 125 milligram of IV solumedrol, and the patient was transferred from floors to our ICU step-down unit. So we tried to get more history from the patient, and then we figured out patient has some high sexual risk behavior. So we got a HIV test. We added a CD4 count as well. And we continued the zosyn in the bank and continued the IV solumedrol given suspicion of pneumonitis given the ground glass opacification. But then on day 7, the HIV test came back positive and the CD4 count came back as 30. And after that, our suspicion of PCP pneumonia became like, it went to the top on the list. So we started IV Bactrim along with the steroids, and we got LDH levels. We got a beta D glucan. The beta D glucan was positive. The serum LDH levels were high, around 540. We did get some other testing like CMV, histoplasma, toxoplasma, but all of them were negative. We got a induced sputum and sent it for PCP stain, but it was negative. But given the high clinical and radiological suspicion, we made a diagnosis of presumed PCP pneumonia, and we kept the Bactrim and the prednisone on. In I think 2 or 3 days, the patient's respiratory status improved significantly. The patient's saturations improved to 95% on room air within 3 days. And at that point, we switched the Bactrim from IV to PO as well as the steroids. And because the CD4 count was less than 30, we started azithromycin for macrophylaxis, but we did not start ART. We started ART after 21 days in order to prevent iris. One interesting thing is the patient developed refractory hyperkalemia when the patient was treated with Bactrim. It was pretty refractory. It required multiple doses of insulin, Lokelma, calcium gluconate. And then we figured out Bactrim could be causing the hyperkalemia. So we switched from Bactrim to atovaquone. And after that, the hyperkalemia resolved. So patient completed 21 days of treatment with combined of Bactrim and atovaquone and steroids. And around 20th day, we started Biktarvy as well. The patient was finally discharged to an assisted living facility, and patient did not require oxygen on discharge.
Oh, fantastic. Thank you so much for presenting this case. Anna, do you have any reflection from the case?
That's a great case with like a nice, I think, natural progression of things that make a lot of sense at different diagnostic standpoints. And so like, you come in and you see this patient who's newly hypoxic and you have a history of getting a ton of fluid. I think it makes sense to go like, yeah, pulmonary edema, like they're super tachycardic, they're agitated, they're like, a middle-aged person, like, sure, they could develop a little bit of flash pulmonary edema. But then what I appreciate your team did was that every time things like weren't following a good or like the natural history of the disease that you expect, you use that as like a pivot point to be like, diagnostically, is this the right thing? And then like changing things. Do you need this room?
No.
Okay. Okay, sorry, I'm in a patient room. Oh, Julie, one of our great ICU nurses. And so I think that that's like such an important thing. Like, I don't think this is a misdiagnosis in any way. This is like a diagnosis that like revealed itself over time as we all would go through a diagnostic approach and thinking about a patient with hypoxic respiratory failure. And, for a patient who's been altered and aspirating, probably absolutely antibiotics. For a patient who's been, potentially not managing their gastric or oropharyngeal secretions. But I think it's really like using those stop points of like, when are things not fitting with my illness script for this problem where I need to revisit the diagnosis. Yeah. That was an awesome case. Can you pull up the CT one more time? Because I do want this. I learned this from Jeff Coley's. I think that's how I say his last name. He's an internist at the VA. He works with Robbie. And he actually taught me this like sign. He worked in San Francisco during, like the AIDS epidemic, and they can, that like cohort of doctors can spot PCP. Like, I'm sure he would have said PCP, like without doubt. He might have even started treatment for PCP looking at this CT, but that's how PCP got its name. So looking at the areas of ground glass, when you see those like little almost walled off areas, those are the pneumatoceles that gave name to the gave name to pneumocystis. And so that's like a little clinical reasoning pearl that I learned from them. And they're so good at diagnosing PCP. I remember working in the emergency department and getting a CT abdomen pelvis on a patient who had HIV and was like complaining of a little bit of a cough, but it was mostly abdominal pain. And Jeff saw the CT just in the basis, saw the pneumatoceles, and is like, send an induced sputum, and the patient had PCP. Anyway, that was an awesome case. Thank you for sharing it. I hope the patient did well from an alcohol withdrawal perspective as well.
He did. Yeah. I think he was fine in terms of alcohol withdrawal by day 4 or 5.
Amazing. Rishabh, do you wanna, I'll ask you too, if you want to share like 2 teaching points from the case that you learned?
Sure. So I actually have just a couple of slides. And I
Okay.
think Anna has already talked about these teaching points, but just to reinforce, let me share my screen again. Okay. Yeah, so ground glass specification, I think that's like a really big teaching point from this case. So just to show some figures, just like very layman, so we have normal lung, we have consolidation, and in between we have ground glass. So in consolidation, you don't actually appreciate airways and blood vessels of going through the area, but in ground glass, you do. So ground glass is denser than normal lung, but as compared to consolidation, it's less dense. So it's not enough to secure the obscure the vessels. And just going over the right slide as well, the consolidation area is going to appear completely white on CT, whereas ground glass would appear gray and normal lung would be more blackish. So going over a differential diagnosis for ground glass, And Anna's already talked about it, but it could be infectious processes like PCP and even other pneumonias like CMV, HSV, RSV, COVID, presents with ground glass opacification, mycoplasma, and even bacterial pneumonias can present with ground glass. It's just less prominent consolidation. And then we have some acute alveolar diseases like acute hypersensitivity pneumonitis, subacute hypersensitivity pneumonitis, ARDS. Cardiogenic pulmonary edema is a really important cause of GGOs. And then we have some chronic interstitial diseases like acute interstitial pneumonia, UIP, which is IPF. Then we have cryptogenic organizing pneumonias and sarcoidosis. And then we have some other causes like drug toxicities and neoplastic processes, which could spread in lipidic proliferative pattern, which is around the alveoli. And then coming on to the diagnostic approach for PCP, which I think is the second most important teaching point from this case. So a definitive diagnosis requires the identification of organism either by dye-based staining or fluorescent antibody staining or PCR, assays of the respiratory specimens. So it can either be done on sputum, which I think for the best deal, we do induce sputum. But the best thing is to do a bronchoalveolar lavage, do a bronch, which we did not do in our case. And then we have a presumptive diagnosis, which is the one we made in our patient. There are times when a definitive diagnosis cannot be made due to low burden of organisms and inability to obtain necessary specimen. In these cases, if there's a high clinical and a radiographic suspicion for PCP, we can just make a presumptive diagnosis. And there are some things that support it, like elevated levels of beta-D-glucan, elevated LDH. And this is the final, it's the treatment. So PCP diseases are differentiated into mild, moderate, and severe, and mainly for treatment purposes. And this depends on the PaO2 and the AA gradient. So if the A gradient is less than 35 and or the PaO2 is 70 or more, then we call it mild. Whereas if the A gradient is between 35 to 40, then it's moderate, and above 40, 45 or above is severe. And for the PaO2, it's 70. More than 70 is mild, less than 60 is severe, and between 60 to 69 is moderate. And this has an impact on the treatment, because in mild, you can just do oral antibiotics, but you don't need steroids. In moderate, you need oral antibiotics with steroids. And in severe, which was our patient, we give IV antibiotics until the patient is clinically stable and then transition to PO antibiotics, and we have to give adjunctive steroids. That's it. Thank you.
Fantastic. Thank you so much for sharing these amazing teaching points. We got to the end of our session. Thank you so much, Anna. Thank you so much, Rishabh, for being with us. It was really, really great. And thank you, Ravi, Kushal, and Parisa for helping with the whiteboard and preparing the case. So yeah, bye-bye, everyone. I hope to see you all tomorrow.
Thank you, Anna.
Thank you, Rishabh. That was an awesome case. Deborah, fantastic facilitating. Thank you for having me.
Thank you,
please
Deborah.
come back. You too. Are
Absolutely.
invited.
It's been too long. I've missed it.
Bye-bye.
Take care. Have a nice day. Bye.